I want to thank everybody who was able to join us today, and there'll be, I think, a few stragglers coming in over the course of the session. But we're very, very excited today to be able to put on this webinar as part of a knowledge translation strategy related to a very substantial program of work that we've been doing related to grief and bereavement in end-of-life care, grief and bereavement during the COVID pandemic. So this is part of a larger piece of work, a larger program of work being done under the auspices of the Pan-Canadian Palliative Care Research Collaborative. And a fair amount of this work is being done here out of Ottawa, but it does include partners from other parts of the country. And so what we were really excited to do here is show you some of the results that have been generated from this work and talk a little bit about some of the future directions. We have an hour and a half, so we're going to try to go over the projects in sufficient detail, but not exhaustive detail to be boring. But we're very grateful for a number of things. So just by way, right off the top, just want to express a lot of gratitude to Health Canada for funding this work and what is obviously a very important area that became, I think, was always an important area, but has become more acutely important in the focus put on this area because of the COVID pandemic and the struggles we've had. The other, so I want to thank Health Canada and the Special Projects funding pool for that. Also, just to do a territorial acknowledgement, land acknowledgement that we're giving this talk today, and the offices of the PCPCRC and the presenters are on traditional unceded territory of the Algonquin and Anishinaabe people, so we honor them. And that, I think, is the most important stuff to say right off the top. Maybe I'll hand the microphone over to Dr. Lawlor, who will talk a little bit about the portions of this project that he was leading.
Thank you, James. I'm going to share my screen, which share screen. Okay, and I'll bring up the main show. Okay, good. Can you guys see that okay?
We see your presenter slides, Peter.
Good, so it's full. Okay, all right. So thank you, James.
Oh, sorry, Peter. I think what Julie was saying is it's in presenter view mode. So I don't know if you can go. Can you go to display settings at the top left, or second from left at the top? Display settings. If you click there, swap presenter and slide view show.
Yeah. Okay.
Perfect.
Now, are you seeing the full slide?
Yes.
Good. Okay.
Real
perfect.
quick.
Okay. Excellent. So James and I are very happy. We actually have a very big team, and I'm hoping that we should very much want to acknowledge all of our large team involved in this. But James and I are presenting today. So I'm going to do the dying bit, and James is going to do the grieving bit, essentially. Before I start, I have to say, we had some debate yesterday about how we might present this information to you, because some of the audience will want some of the statistics, and I've no doubt that there are some people in the audience who don't want to hear about any, major statistics in great detail anyway. So we worked out a sort of a hybrid, and it's a bit like a sort of going into a restaurant and you ask for the table d'hôte or you ask for the a la carte. So the table d'hôte is compliments to Fiona Kenny, who's our KT specialist, and she has actually done some infographics and made it more digestible for somebody to sort of get the bottom line, essentially. And the a la carte is the sort of some of the statistics, although I'm going to try and keep it brief. I've tried to highlight what's really important. So it's a la carte without necessarily going into the calories for each bite of food, if you follow the metaphor. Moving on, the main objectives for this whole entire project was we wanted to look at, I suppose, first off, end-of-life practices, that is the type of care, medications given, supportive care, and the presence of family and communication at the end of life in those who died in wave one of the pandemic. We wanted to look at the impact of the pandemic, both the illness itself and also dying in the pandemic, those who didn't die of COVID-19, but yet died during the pandemic, the impact on grief and bereavement in family caregivers. And then lastly, the third objective here, which we didn't, we started out with the intent of offering, well, we did actually offer support group to the family members, the bereaved family members, but the uptake was very little. But so we have very little, we have no data really to report on that. So the structure was initially, I suppose, essentially a chart audit. We have about 425 patients in the sample. It's a matched cohort study, which I'll go into a little more detail in a minute. And we pulled their demographics. We pulled information from the electronic medical records, and we created a database with the end-of-life care received, the consults that were made, the symptoms that they presented with, and also communication, basically documentation of communication, whether it be virtual or in-person meetings. And then James is going to follow up and tell you about the bereavement outcomes for the family members of this decedent cohort. So this is the first paper, and this is the first one that I'm going to report on, and that is looking at comparative end-of-life communication and support in this study sample. This is published in the BMJ Open. I think it was in June of last year. And I think, we probably hijacked, I suppose, James's ICU bereavement project, which was scheduled to take off just at the beginning of the pandemic. So we hijacked his sort of structure and format and design for that study to a large degree and used it for the COVID project. You know that the pandemic was declared on March 11th, 2020. There was pretty significant wave one mortality and morbidity, and I probably don't need to tell you too much about this. A lot of hospitalization, ICU admission, and a lot of deaths also in long-term care. And I think there were many publications at that time, at the beginning of the pandemic, highlighting the need for good communication, good end-of-life care. We knew that services were stretched, but there was a need for palliative care involvement and support, and there would also be pretty significant bereavement concerns and grief on the part of the family members of those patients who died. There was a lot of controversy back at that time over the visitor restriction and isolation policies and the impact that might have on subsequent grief in family members. So the aim then was to look at end-of-life communication. This particular paper, we're looking at end-of-life communication and support. Sorry, I'm going to shrink this here. In the acute care hospitals in Ottawa, one quaternary hospital, the Ottawa Hospital, and the other two tertiary hospitals, Queensway Carleton and Montfort. So we compared communication pre-pandemically with care during wave one of the pandemic, according to COVID-19 status. We basically wanted to look at the impact of COVID-19 on patient-family communication and also healthcare team family communication at the end of life. We, as a sort of a secondary objective, we wanted to look at the consultations to allied health and the level of palliative care consultation as well. And then, of course, the larger project would be looking at bereavement in the decedent's family members. So our underlying sort of hypothesis with this was that, in terms of communication, was that the visitor and family visitor restrictions and isolation restrictions would essentially mean, less in-person and face-to-face communications, both between the healthcare team and the family, and also family and patient, and that these restrictions would possibly mean that people would use other forms of communication, like video conferencing, FaceTiming, or using the telephone more. This is multi-center, as I mentioned. It's a retrospective data that we pulled. It's a matched cohort study pulled from the electronic records. The eligibility was that basically criteria were that patients had to be over 18 years of age. They died either in intensive care or under a medicine service. And this allowed us to, first off, look at all the deaths in the period from February to August of 2020. So there were 85 deaths in total. So that was the index group, all the acute care deaths in those 3 hospitals. And that was our index group. And with those, we matched 2 to 1 from a pre-COVID group, which was before the pandemic, and also a COVID group. And they were matched on the basis of age within 5 years, sex, and also the care service, whether it was medicine or ICU that they died in. So moving to the sort of more a la carte little bit, looking at some of the stats, it's important for me to highlight here that, I don't know if you can see my cursor, that 50% of in the COVID group, this is the COVID group here, the 85, and this is the COVID negative, but during the pandemic, and this is the pre-COVID group in this column. So 50%, as opposed to either 12% or almost 5% in the pre-COVID and COVID negative group, 50% came from nursing home long-term care. So this was a very frail population. There was no difference across the study groups in relation to age because they were matched, and they were matched on the basis of sex as well. And no other significant differences noted either. The proportions of medicine versus intensive care were the same in all the study groups. And the admission duration did not differ across the groups either. There was a documented, thankfully, no CPR order across the board in about 95% of the patients in all study groups. So there was no difference in that regard. And that, nor was there a difference in relation to the timing of the placement of that order either. So back to the a la carte mode. This is basically a summary of what we're looking at here. If you don't like statistics, this is just basically 3 adult hospitals. Most were male, average age was 79, so an elderly population. One group died pre-pandemic. This is the pre-COVID group, 170, 1 COVID negative, and 1 COVID positive, the 85 patients that were COVID positive. And this is the time period here that we're looking at. So looking at the referral source, this is just, I think I mentioned this statistic already. You can see here just in clearer form graphically that looking at the nursing home referrals across the groups, this fawn colored is pre-COVID, blue is COVID negative, and the green is COVID positive. So you'll see the big difference in terms of the long-term care nursing home referrals from the COVID positive group. And looking at the in-person presence of family with the patient in the last 48 hours of life, this was a logistic regression model. And I'm going to draw your attention to basically this column here, which is the adjusted odds ratio. And you will see that the odds here of this is the pre-COVID group. And this is what we refer to as a reference group. So with reference to the pre-COVID patients, the odds of an in-person visit from a family member in the last 48 hours of life was reduced by 62%. So it's 0.38, you see the odds here. And this was reduced even further. That's in the COVID negative group. And it was reduced by 91% in the COVID positive group. There was also a site difference, which we do have to acknowledge, but I don't think that explains all of the findings. There was a site difference. One site had less visits from family members in person than the others. There were no other differences in relation to age, sex, or care service at death. So summarizing that, again, back to the more table d'hôte menu, this would mean that 90% of the pre-COVID patients had a visit from a family member in the last 48 hours of life, but the COVID negative, or COVID positive, I should say, had only, that was down to 47%. So a dramatic reduction. Looking at virtual communication then, and by virtual communication, we mean those that would either have a laptop to communicate, via FaceTime, Skype, or a cell phone where they would FaceTime. And you can see here that virtual communication, again, this is a logistic regression model, and it looks at the odds of having this type of communication, virtual family presence in the last 48 hours of life. So you will see that virtual communication, the odds compared to the COVID negative group, we were not able to compare to the pre-COVID group because there was very little virtual communication documented in the pre-COVID group. But certainly in the COVID negative group, it was documented, and it was 3 times greater. The odds of having that type of communication, virtual communication, in the last 48 hours of life was almost 3.5 times greater in the COVID positive group. And also, if the family were not present in the last 48 hours of life, then it was much more likely to have virtual communication. Again, that's not rocket science. If you can't communicate in person, that people communicated virtually. And there were no other predictors in that model. So again, 10%, this is just looking at it graphically, 10% of the COVID negative and 31.8% of COVID positive had family present virtually. So again, a big difference between the two. If you were COVID positive, you were much more likely to rely on virtual communication. There was also increased telephone team family encounters as well, which I'll come to in a minute. So, so I think that, again, this is pretty straightforward, I think, and easy to understand. Those not physically present were more likely to be present virtually. Looking at the number of encounters between the healthcare team and the family in the last 5 days of life, not the last 48 hours, but in the last 5 days of life, we had to use a mixed effects negative binomial model. Now, that's all to say that we had to factor in, it was not just one encounter, we counted the number of contacts between the team and the family members. And first off, looking at in-person face-to-face encounters, you will see from this that that there was a reduced number of encounters for those males that died, and there was, compared to the pre-COVID group, this is the pre-COVID here, the reference group, there was approximately down to 0.76, which is a 24% reduction in the in-person encounters between the team and the family members. And there was approximately a 40% reduction for those patients who were COVID positive. That is, encounters between the team and family members. Again, it was even more pronounced in the intensive care setting. Those patients who died in intensive care, the reduction there was almost just a little over 30%, 32%. And then looking at telephone conversations, again, compared to the pre-COVID group, which is the reference group, there was increased use of telephone in the COVID negative group, and also much greater use of telephone between the team and the family members. The incidence rate, this is an incidence rate ratio. So this is the number of cases or the number of times. So that incidence went up. It was a factor of almost 5 times greater compared to pre-COVID that people use the telephone to communicate. So again, it's not rocket science, and there were no other significant predictors in this model. So again, you see here that the in-person contact went right down in the COVID positive group. You can see it here, and the telephone communication was much greater. So, sort of in concluding then, the physical presence of team and family, it was drastically reduced for the COVID negative and COVID positive groups. And both groups used more virtual communication with family. And COVID negative and COVID positive groups used more phone communication as well between team and family. So I suppose the implications are suggested implications of this is, the presence of family at the end of life is significant in terms of subsequent grief, and these changes that can compound certainly both patient distress because many patients died alone, and then there is the risk of complicated grief in the family members of deceased. We also looked at referrals to the support services, and you will see from this that physiotherapy in the COVID positive group, there was a marked, compared to the COVID negative or the pre-COVID group, it was only 24% versus 50 or 41% and similarly for the social worker involvement was reduced as well, and also occupational therapy. The biggest use of these services, physiotherapy, social worker, and occupational therapy, was with the COVID negative group, surprisingly. But we speculate that this may well be that they were trying to move these patients home. They were COVID negative. They were trying to get them out of hospital. So they may have had more involvement. And those services were less deployed, I suppose, with the COVID positive group. Anyhow, that was the case. And happily, we were able to report that spiritual care and palliative care consults didn't change across the 3 groups, the pre-COVID, COVID negative, and COVID positive groups. The consult rate was about 30% in the COVID positive groups, a little bit better in COVID negative at 41%, and pre-COVID 41%. Those consults tended to be a bit late. The median number of days was 3 days before death across the board, but no difference among the groups. So again, this is just summarizing the professional involvement here, and you will see the allied health. You will see that in the COVID negative group, physio, social work, blue is the COVID negative group, OT, much more involvement, okay? There was no significant differences in spiritual care or palliative care across the groups. So paper 2 then, we wanted to look at basically medication use and symptom control, and I suppose comorbidities as well in this age group. The problem with a lot of the data that was in the literature and is still in the literature is that there are very few reports where they actually have a comparator group. And we have the advantage of having a comparator group from within the pandemic and also a comparator group pre-pandemically. And most of the reports on opioid requirements and end-of-life medications would suggest that in the literature that the management of COVID-19 deaths, people who die of COVID-19 infection, their requirements are somewhat similar to those of other end-of-life conditions. Having said that, some of the reports mention somewhat higher requirements. So our hypothesis, based on clinical experience, and now James certainly has had his finger very much on the pulse here because he's had some exposure to intensive care, palliative care, and even did some visits to long-term care. So based on our clinical experience, we hypothesized that higher opioid and sedative doses were needed to control symptoms in hospitalized patients who died of COVID-19. And we wanted to look at conventional palliative medications, which I'll show you in a minute. We wanted to look at their use in the last 72 hours of life among the three groups that we referred to previously: the pre-pandemic group, the COVID-negative group, and those who died of COVID. We also looked at admission comorbidities and symptoms on admission. Unfortunately, we don't have symptoms documented clearly or in a standard way at the end of life, but we do have admission comorbidities and symptoms. So this is just, again, the three groups that we referred to previously, and we included the full groups in terms of admission comorbidities and symptoms. We had to exclude 7 patients from the pre-COVID and COVID-negative group because they died less than 24 hours when we were looking at a comparison of medication, okay? So there was slightly reduced numbers, 163 in each of the 2 control groups, and these 85 COVID patients were compared for medication. So this is the comorbidities on admission, and you will see here the striking finding here, I think, is that surprisingly, atrial fibrillation was less in the COVID positive group, but that's sort of against a lot of what was reported in the literature. But anyway, that was our finding. Dementia, though, was certainly almost double in the COVID positive. The green is the COVID positive. This is the pre-COVID, COVID negative, COVID positive. And also the general comorbidity burden was much higher in the COVID positive group versus the other 2, the pre-COVID and the COVID negative. Symptoms at admission then, surprise, surprise, breathlessness in the COVID positive group, particularly high, cough particularly high, pain a lot less, fever high, and these patients needed high flow nasal cannula, oxygen with high flow nasal cannula. Looking at the opioid use then, again, without going into too much detail, I can tell you that most of these patients, thankfully 90-something% were prescribed an opioid, and the administration was pretty much 90% or greater as well. And particularly in the COVID positive group, 95% of them got an opioid in the last 72 hours of life. Okay, this is the COVID positive, COVID negative, and pre-COVID groups. The usual run of the mill in terms of opioids, but no difference across the groups in terms of type of opioid prescribed, or even the number of patients who received an opioid. There was also no difference across the groups in terms of the percentage of patients in internal medicine or intensive care. When we compared those subgroups, there was no difference in the number that received an opioid. The big difference was in the dose. This is where the difference arose. So what we did was we looked at time 3, which is 72 to 48 hours before death. Time 2 is 48 to 24 hours before death, and time 1 is the last 48 hours. And you will see here across all of these that at all of these time points, the median dose was much higher in the COVID positive group compared to the other two. COVID negative and pre-COVID were quite comparable, similar doses, but certainly in the COVID positive group that had a much higher dose. And this is just a graphic that shows this. So as you go towards T3, as I said, was the last 72 to 48 hours, and T2 in sort of maroon color is 24 to 48, and the green is the last 24 hours. And you will see, even in the pre-COVID group, the trend is in the last 24 hours or throughout the last 72 is for the dose to go up. The same with the COVID negative, the same also pretty much with the COVID positive, but you will see that these are medians and quartiles here. You'll see that the doses are much higher in the COVID positive group. So we then looked at the subgroups, and we found that where we wanted to see where the difference was in terms of, would there be a difference in terms of internal medicine versus intensive care? And there was. Looking at the median doses, you will see a very big difference here in relation to the intensive care patients who died in intensive care. The median dose here was 52.5, whereas pre-COVID, that would have been 25, so it's almost double. Significant difference. So dying in intensive care was associated with higher opioid dosing. There was also a site difference, which we do have to acknowledge, but I don't think that explains all of the difference that we found in relation to the COVID group, but we do have to acknowledge that there was one site difference there. So without going into too much detail and without panicking, just looking at this, I just want to ask you first just to look at the blue arrows, which just looks at all aggregate measures of the last 72 hours. And each one, the maximum morphine equivalent daily dose, the individual mean for a patient over 72 hours, the individual median for a patient over the last 72 hours, all of them were much higher in the COVID positive group. And when we did a breakdown on each one of those aggregate measures, we found that the intensive care patients, that difference held for all of the intensive care subgroups, but not for internal medicine. So again, pointing the finger that these patients, particularly those who were admitted to intensive care, required higher opioid doses. So this is just in summary, essentially, the COVID opioid use was much higher in the COVID positive group, but increased in all patients in the last 72 hours of life. So other medications, no difference in terms of anti-secretory or antipsychotic medications. There was a difference in relation to lorazepam, which is the benzodiazepine. There were higher doses in the COVID positive group. Also, out of interest, the midazolam, there was no statistically significant higher use of midazolam, but the doses were certainly higher, but not statistically significant. And looking at propofol, which is a sedating agent that's used in ICU, the maximum dose of propofol was very significantly higher in the COVID positive group compared to COVID negative or pre-COVID. So the conclusions then were that those who died of COVID-19 infection required higher doses of both opioid and lorazepam, and than those who would have died of other causes both before and during the pandemic. And patients who died of COVID infection in ICU required higher maximum 24-hour propofol doses than those who died in ICU without COVID-19 infection or before the pandemic. So the implications would be that, that this needs to be, we're in the process of submitting this for publication now, but the breathlessness and agitation due to COVID-19 and the higher underlying comorbidity levels may altogether require higher doses of opioids and sedatives just to get good symptom control at the end of life. And I think this probably should be written into the guidelines. It's important to know in the current context of the current pandemic, which is still with us to some degree, and also in anticipation of future pandemics as well. So I'm going to hand it over to James. I don't know if we want to take questions now or do we want to take questions at the end?
I think why don't, because it might be good to do sort of questions and discussion together at the end.
Yeah.
My section's a little shorter than yours, so I feel if people are okay to hold their questions, or if you have comments, feel free to write them in the chat and we'll make sure we get to them. Okay, so I am going to share my screen. Oh, can you unshare your screen, Peter? I think I'm.
Yes. So where do I go for that?
You got to go to the top, and then on the top you click and it pulls down, and there's a stop share, I think.
James, you should be allowed to go ahead now. I just changed it.
Oh, okay. All right. Share screen. Okay. Can everyone see slides?
Yep.
Yes.
Sorry, I apologize. I'm just going to go to this part here. So yeah, just going to switch gears and now talk about going from the end of life care provided and some of the key findings there, which I think those of us who were on the front lines of COVID, I think it really reinforces a lot of what we saw. But then talking a little bit about some of the bereavement experiences where I think, we may, even though those of us who are quite closely involved, I think we lose track sometimes of family members. And so we were really keen as part of this work to get a better understanding of what the bereavement experiences were for family members who died. And again, looking at the same groups. So, and again, this is maybe an opportunity as well, just to flag, and this really was a team effort, and we were very fortunate to have so many people from the Ottawa group involved in collecting data across multiple sites. It kind of gives us a real snapshot of the whole city rather than just one or two hospitals or just a single specialized center, but really to get all of it. So, and particularly for the bereavement part, really big thanks to Manisha, Chelsea, Brandon, and Kobe, who really were involved in helping to track these people down and get what turned out to be some very, very good follow-up and good, very comprehensive results, I think. So again, looking at just a bit of a background on bereavement and bereavement experiences during the COVID pandemic. There have been a number of studies that have been published on this now, but a lot of them were done a bit differently than what we did here. So there were studies that were generally online surveys. So you kind of post a link and people can write in and talk about their experiences. So often there can be a bit of a bias in terms of who's responding in a situation like that, as opposed to a situation where you're prospectively following a cohort and trying to get them to all participate. These are convenience samples, right? So sometimes you get tilting things in one way or another. They also used very different measures of grief, and there is no one single accepted measure of grief severity, but depending on the definition and the tools used, and of course the types of studies themselves, you would see quite a dramatic variability in prevalence of severe symptoms. So up to as high as 70%. One of the key things when you study grief and complicated grief is the timing of when you assess it. So one of the classic teachings around complicated grief and bereavement are that you really shouldn't do it in the initial days or weeks following the loss, that there's a certain even quite severe symptomatology that you can experience early on that is not considered pathologic, right? That you have to wait a little ways going out to about 6 months if you can. And so almost all of these studies were done quite early after the loss. And so it could suggest, it could easily have overestimated the prevalence of what we might consider prolonged or severe grief compared to what we would normally do in normal times. As a rule, when you compared and when the studies were done head to head, the types of outcomes that you saw would have been very comparable to the grief the rates of complicated grief that you see with unexpected deaths. So in general, when we look at populations and we look at bereaved family members or close ones, you tend to see, a prevalence of severe symptomatology in the sort of 2 to 3% range, and it goes up in certain populations. So typically, for spouses, it's a little higher. Women over the age of 60, it's a little higher. People, when the loss occurs in a critical care environment, the numbers are a bit higher. And then unexpected deaths, so like a traumatic death or a sudden death like a heart attack and cardiac arrest, though without any sort of prior illness or severe illness to get people ready, you tend to see higher rates of complicated grief. So the numbers that we were seeing, and when they did comparable studies involving lots of groups, that the rates you saw in COVID deaths were often very similar to unexpected deaths. And just important pointing out. So again, here we're looking at a slightly different population than what we were looking at above, and I've got my laser pointer out here. So again, we had the same three cohorts. You had your pre-COVID cohort, you had your COVID positive cohort, and you had your COVID negative cohort. And in this case, we weren't actually looking at the patients themselves, but their next of kin. So we tried to contact their next of kin. And again, these numbers are sort of in the 40-50% range of overall is actually fairly typical of bereavement research. It can be very challenging to get people involved. So these numbers may not look extremely high. These are actually pretty good numbers for enrolling bereaved family members. And because of the timing that we did this, we were actually able to, enroll family members and look at their bereavement experiences because we started the study so closely to the start of wave 1 that we were able to get a reasonable comparator group from this COVID negative, or sort of, I should say the pre-COVID, I apologize, the pre-COVID group as an appropriate comparator. And again, big kudos to our study staff to get a very high rate of participation, sort of 60 to 80% ranges. This is very high for bereavement research, and just again, a testament to, it's hard to do. It's hard for bereaved people to want to do a long survey, and it can be very taxing on study staff to work with people who are bereaved. These are very awkward conversations sometimes, so it takes patience. And in a couple of cases, we enrolled some additional and next of kin just to beef the numbers, but it was the same from each group. And so at the end of the day, we got a pretty good set of comparators to look at here. In terms of the next of kin population we were looking at, again, as is typical in studies like this, about 2/3 of the population were female. So as a rule, when you look at dying cohorts, it tends to be slightly more male than female. When you look at next of kin cohorts, it tends to be more female than male. Average age was about 58. About 2/3 were the children of the deceased, and in some cases a smaller number, the spouse, and then there were more distant relatives. As a rule, we had a population sometimes that with end of life and bereavement research, there's a risk that you tend to get far more majority culture than average. Just that's who responds to these types of questions due to stigma or other cultural factors. But in this case, we actually got, although the majority was Caucasian, these numbers this is actually a lower than Canadian average number. So what certainly we had what would be considered a very representative group of Ottawa population, and actually fairly representative of the Canadian population as a whole. And the large majority had no history of any mental health conditions at all, right? So this is, a concern sometimes in bereavement is if you tend to preferentially get people with long history of mental disorders or mental illness, that you might be frustrated by that you'll see unrepresentative numbers as a result of that, but that probably wouldn't be the case here. And then you see a fairly large number of people with some post-secondary education. Again, it's Ottawa, so it tends to be higher than the national average. At least as long as you're not talking about politicians, I guess. Then when you look at the COVID status groups, right? So looking at here, so this is the main result. So we use something called the Inventory of Complicated Grief Revised, and it's a sort of validated tool looking at grief rates. And there's a cutoff number of 25 that is often used to delineate severe symptoms from less severe symptoms. Again, it's not like, if you're 26, you're terrible, and 25, you're fine. But that's generally speaking the cutoff used in a lot of literature. So we use that here. And we've used that also in previous ICU studies, and we found a really high prevalence of complicated grief, so 26 to 30%. So to give you some comparison, as I say, average bereaved populations, you'll see sort of in the 2 to 3, maybe 5%. Looking at critical care, we did a critical care study, which is a higher risk group, and we were in the sort of mid to high teens. So 30% is much, much, much higher than you would expect for this population in pre-COVID times. But what was very interesting was that it was high even in the pre-COVID period. It wasn't lower. This is not statistically lower anyway. And then, so we tried to also break it down to see, was there any suggestion that this might have been related to things that are known to be associated with higher risk of severe grief symptoms. And so there's something called the Brief Family Relationship Scale, and it tends to indicate sort of the degree to which there's conflict or lack of support between you and the loved one. Higher scores are worse, lower scores are better. But again, there didn't seem to be any difference between those scores among people who had severe symptoms versus people who had less severe symptoms, right? So you would expect to see worse outcomes sometimes in different types of relationships, but that didn't seem to hold in this study. Also, when we looked at sort of physical presence or absence of the family at the time of death, again, a common factor that is well known from other studies to indicate or to put people at risk of more severe symptoms. And in fact, it didn't, right? So there was no obvious differences in whether or not somebody had severe symptoms based on whether they were there or not. There was a slightly but not significantly lower rate of severe symptoms in people who were not present. And so usually not being present gives you worse symptoms. So again, this is normally a factor that you would see a difference, but you don't in this population. And the other one is intubation. So if the person was intubated, typically people, when a deceased person was intubated at or around the time of death, the grief symptoms are worse. And in this case, they were not. So again, it was high, and it had didn't seem to have any relationship to whether the person died of COVID, died of something that wasn't COVID during the COVID period, or even died shortly before the pandemic. And we were assessing the family member during the pandemic. It just seemed to be really bad regardless. And so that was really a sort of interesting finding that we were not expecting. So, and then big thanks to the research staff again, who went on to start to collect data, a 6-month follow-up. So typically we assess people more than 6 months after their loss, and then did a follow-up 6 months later, and really big kudos to the team that got over a 90% follow-up rate, which again is almost unheard of in bereavement research. So really fantastic job by them. And again, this is a very messy graph, but it's meant to sort of convey what did it look like over the time between the baseline assessment and 6 months later, what happened to symptom scores. So you see here on the y-axis, this is the severity of the score, the severity of the symptoms, 25 usually being the cutoff between more severe and less severe. And then what you'll see is everybody's connected. We've drawn lines connecting their baseline assessment to their 6-month assessment. All the green lines are people who started off below 25 and stayed below 25. All the orange lines are people who started off above 25 and stayed above 25. And then the red lines are the people who started low and went high, and the blue lines who started high and came down. You can see as a general rule, there's a lot of the green lines, like in general, a lot of these lines got a little bit better, but certainly a few got substantially better, and quite a few got substantially worse as well. So no obvious signal just quickly looking at these numbers. And again, the average symptom severity between baseline and post 6-month follow-up did not change. There was also, in terms of the proportion that had severe symptoms, that also didn't change. It stayed at 29% pre versus post. And again, there was no real difference in the evolution of symptoms, regardless of whether you were, the loved one died of COVID, died of something other than COVID during the pandemic, or died of something just shortly before the pandemic started. What was interesting, then we kind of pulled together a group that consisted of the people whose symptom scores started high and stayed high, and the group whose symptom scores started lower but became high after 6 months. And looking at those, because we felt like those were probably the people who were doing obviously a lot worse. And was there any way of predicting, were there any demographic associations with the group that was doing worse? And unfortunately, we found is that it would seem to be more common, statistically more common, if the deceased was intubated, I should say intubated, not intubation. But it was not correlated with the COVID status or whether or not the person was present at or near the end of life, which again is very much contrary to what we would have expected, sort of an unusual finding for us. So going back to Peter's table d'hote analogy here. So this is the bereaved family members of the same destined groups were assessed for grief symptoms. About 29% had severe symptoms, but it was similar across patient groups. And again, when we followed them 6 months later, not really much had changed in those 6 months. And it was very, very notable that the same symptoms, more or less the same symptom scores were seen even among family members who lost people before the pandemic started. So their death experience and their experience of loss was essentially unaffected by the pandemic, but their bereavement experience took place mostly during the pandemic. And when we assessed them, it was during the pandemic. And their grief symptoms seemed to be extremely high, much higher than the similar numbers that we had measured in the Canadian population prior to the pandemic. So again, really raising the question of what we classically think of as the bereavement experience being heavily influenced by what's happening at the time of death and before the time of death for the person, for the bereaved family member, is heavily seen. We've always thought of those events as being really important for that bereavement experience. But in this case, it actually seemed to be the opposite, that in fact, it was, if anything, it was the pandemic experience and what was happening following the loss that seemed to be decisive in indicating like how bad your symptoms were going to be. So I think the bottom line here is that, something inherent to the pandemic itself that was really causing problems, and then an ongoing need to both prevent and or treat the grief that followed the COVID pandemic. So just on that note, sort of what are things we can do about this? We, as part of the study, we had engaged with bereaved families of Ottawa to engage in these sort of virtual support groups. We're really keen to make sure people were getting connected with services. And between that sort of baseline and 6 months, we actually gave them a referral and said, please go and attend these sessions, and didn't oblige them to do it, but suggested it. And amazingly, not one person ended up doing that. And we were very puzzled. We were unclear as to why they didn't, but we're getting a bit of data on that now. In general, we'd hope to be able then to look at that and see if these virtual support groups might have been helpful, that they could be, of value to other communities dealing with subsequent waves. But we didn't actually get any of that data. So as we said, turning back to some of what's already out there in the literature, there is a fairly, there's a fairly small body of literature, although reasonable, looking at the effectiveness of interventions that are used to improve grief symptoms. There's something called complicated grief therapy, which is a form of sort of psychotherapy, but is more focused on helping people unpack and stop ruminating on aspects of the loss, which it's this rumination cycle that's responsible for many aspects of mental illness and in many conditions. And in bereavement, it often is this rumination on the loss and rumination on details of the death that seems to drive people to kind of drive their symptoms and drive these really severe emotional responses that people can get to loss. And part of trying to interrupt that is to interrupt the rumination itself, and then also help people to sort of invest into more relationships with others and start to rebuild a social structure so that they can start to function. It's very hard to do when you have these sort of really painful and difficult emotional outbursts at times, and when you're exposed to reminders of the loss. And so many people tend to sort of go back in their shell and ruminate, and it only kind of seems to contribute to making things worse. So complicated grief therapy is aimed at that. Medications by themselves don't seem to be all that helpful for complicated grief symptoms, except insofar as they help people go through complicated grief therapy. So the two together seems to be synergistically beneficial. Group therapy has been also found to be somewhat useful in this context, although there is a lot of sort of smaller studies and somewhat biased. There does seem to be an inherent value from a lot of studies, and people report that being in a group of people who have had similar experiences can be very helpful, make people feel like they're not alone. and that what the comments and the support that they receive is not just generic support. It's actually somebody who feels a little more invested and a little more relevant to what you're going through. Of course, the challenges in the pandemic, which I think we're well familiar with, there were so many restrictions on in-person interactions. So our standard sort of group therapy approaches and psychotherapeutic approaches were deeply disrupted. There was obviously a big disconnection between patients and staff. So sometimes when we have a sense that a family member is struggling, we sometimes can intervene, hook them up with resources, and that really was just not going to happen very well during the pandemic because we didn't see them as often and the resources were not able to engage. And of course, as people went into the bereavement period, this disconnection from social supports and other services was quite profound. So there was an awful lot of suffering and silence that went on among family members. There's no question. Instead, we pivoted a little bit with our study and with our work here and we've now done a sort of a quick review, a literature review to look and see what's been published. What have people tried during the pandemic that might be of value that we could offer. And we were able actually to identify 7 published studies from the literature looking at this. 2, interestingly, were actually RCTs, 3 pilot studies. 4 were from Asia, and only 2 from North America, 1 from Europe. And a number of these were multi-center. As is the nature of bereavement research, they weren't huge. So these 7 studies altogether had less than 500 participants. It was mostly partners and children of the deceased, and again, consistent with bereavement research, mostly female. So we're still working through these results, but most of them focused on group therapy and peer support, as we talked about, can be very helpful for people to meet with those of similar bent. Interestingly, one was a Japanese study looking at gardening, that was, so we included that. Gardening, I guess, can be an intervention, although if you don't have a garden, I'm not sure what you're supposed to do about that. Go dig someone else's garden, maybe. But the studies themselves, again, 3 were actually in person despite the restrictions, and then the rest were virtual or hybrid. And they, again, measured a number of different outcomes, including grief and depression and anxiety, but they measured with inconsistent studies. So we're still trying to pull together to see what we can pull from this. And Kobe Anderson has been doing this work, and it's challenging work sometimes to try to pull together data from different studies that didn't use similar techniques, but he's on top of it. What we can say is that there was, very often a sort of, among the published studies, a moderate to large improvement in either grief, depression, anxiety, or anger. Interestingly, gardening turns out to be extremely effective at reducing your anger level. And I don't know, I garden a fair bit, so maybe I'm just not doing it the right way, but any gardening pointers to reduce my anger would be much appreciated. The one challenge with these studies, though, as is the challenge in a lot of sort of bereavement work, is that a large number of people are lost to follow-up. So you enroll people, you're trying to do an assessment at the start, and then you put them through an intervention, then you do an assessment at the end. And then what happens is if a lot of people drop out of the study and they don't show up for the follow-up and get that mix, you can't do a comparison between them. So what ends up happening is this is a bit of an attrition bias where, if the people who drop out are usually not randomly dropping out. It's very often the people who are really not doing well with the intervention who drop out. And the people who stay with the intervention are the ones who seem to be more likely to do well with them. And so when you see a sort of an improvement, but 20 to 30% of the population dropped out, is that because of attrition bias, that only the ones doing well stayed with the study and made it look better than it really was? Or was this actually a really crackerjack intervention? At the end of the day, what we really need is something that's going to be fairly routine, something that's going to be scalable because of the magnitude of the need, but also acceptable to people, because it's clear there's a hesitation to engage in bereavement support services, and finding that magic timing and the type of support that people might get, it's far from easy and far from straightforward. And again, even in an environment where there are cost cuts and we are short-staffed in a lot of different areas, we have to justify what we're doing, right? We have to be able to show that what we're doing is effective, but also that it's cost effective, right? So we can't go planning to do interventions that are extremely resource intensive when we don't have those resources. And a small benefit certainly wouldn't be justified if it requires a lot of resources to do in an environment where we're really struggling for mental health resources or social supports. There's a number of further areas of work that we're doing here as well. Like we're starting to dig as well into health services research and looking at healthcare utilization among bereaved caregivers using population-based administrative databases. Ontario has fairly good data on this that we're going to try to dig through. We're also doing environmental scans and key informant interviews, again focused in the Ottawa area, but with the idea that this will be helpful for designing programs and supports that might be usable more broadly, looking again at services and gaps in services, and then ultimately trying to do a systematic review of other community-based interventions to see where that leads. So that's the end, and I want to thank you guys very, very much for having joined us for this seminar. We have a good almost half hour here that we really wanted to leave at the end for discussion about other people's experience with this, understanding that everybody's probably had a slightly different experience with bereavement and bereavement supports. But I want to once again thank everybody who was involved in putting this together. Julie and Gael from the PCPCRC, Fiona, our KT guru for the really impressive graphics that she threw together. A big thanks to Health Canada and Special Programs for funding and supporting the PCPCRC and other funders, including the Berea Research Institute and the University of Ottawa Department of Medicine for funding some of the research that we presented here today. So I want to thank you for that. And yeah. Turn it over to the rest of y'all for questions. And I see Debbie Lasselle is quick off the mark. Debbie.
Hi, thank you. This has been wonderful, very informative, and thank you for all the efforts and thoughts you've put into this. To the end part about complicated grief, I have experienced a lot of that in my life. I speak openly about it. It's not a secret to anyone who knows me. One of the situations was a younger sister killed herself and her 2 children. So at that time, my other sister and I, we went to bereaved families. They had an SOS. Anyway, group, I believe was the acronym they used, something of suicide anyway. Survivors, that was it. Survivors of suicide. And that was our one and only time to go, because when they went around the room just went dead when we said why we were there. And that is not a unique experience. Whenever, well, I don't mean that that's not a unique experience. Yes, what I mean more is whenever any kind of whether it be through a drug death, or I've come to find out anything that is not kind of socially, well known or, common, people just don't know what to do. And so right away, you get that whole, it's an isolating thing, I guess is what I'm trying to say. So I think was your last slide there where you're saying, I forget what the title of it was, but looking at healthcare, what the use of healthcare is after a death like that. That's a very important one, because I didn't realize it at the time, and I've had the opportunity of many years after to deal with some of these things and work on them. But I thought it was menopause. I started going to my doctor. I didn't know. You just don't understand. You're just in this place that you don't even know where you are. And it was a very experienced, very kind doctor we had at the time, who just kind of sat back and said, "Deb, how are you doing?" And a dam broke for me. And it was the first opportunity where someone was really listening and not kind of going, whoa, or saying something to me like, did she have mental illness? Like, no, really, but people, I get it. They don't know what to do. So this is really important work. And for me, just having a place, I tried groups that didn't work for me, but that's not to say they don't for others, obviously, but just having some trusted friends who I knew weren't going to, would just listen. It's like you do in hospice care or anything else. Just sit with someone, just be there, be beside them. They don't need you to tell them what to do. They don't want you to tell them what to do. They just need to know and feel that they're accepted. And for me, that helped me make a slow start. So thank you for everything you're doing.
Thank you very much for those comments, Debbie. One of my favorite quotes in palliative care is, it's the old, don't just do something, stand there. And
yeah.
It's not generally how we're built in healthcare to stand there and be more passive. That's not a that's I think we're, as a general, it's not that we can't do it and we don't do it, but I think in general most of us are much more comfortable if, well, here's what you have and here's what we do. When someone confronts you with a scenario like the one you're describing, which is just gobsmacking, and I'm just I can't even imagine what that's like. I can certainly see why a group therapy would be really challenging. I would say conversely, though, it would be interesting to hear from other members of the group about what the effect on them was of you telling the story. My guess would be, and it's purely speculation, that you probably helped a lot of people by being open and sharing your experience, because what a lot of people say is that they just, it's not that it's, you're not grief is not competitive. You're not trying to sort of outdo the person in the chair next to you. But boy, is it a comfort sometimes to know that there are other people who are as deep into a big dark hole as they are.
That's it, because you know what? I don't expect anyone to understand it. My husband didn't, no one can. He knew all the situation, what led to it, because yes, she did have mental illness for many, many years, untreated, unfortunately. So, but I don't expect anyone to understand it, because I don't. I still don't, and I never will. But that's why the only other thing I'd like to say, please, and not dominate here, I hope that the healthcare workers that were involved with the folks from the first piece with Dr. Lawlor, and holding the phone and so on, I can only imagine how hard that must have been for them too, because it would have had more, I would think, of a close interaction than normal. If the family members could have been there, perhaps they wouldn't have been. So I hope that someone's looking at that for the sake of the healthcare workers too. Thank you.
Thanks very much, Debbie. Julie, your hand is up.
Yeah. Hi, Debbie. I just wanted to add a little bit to your comment and follow up to some of the health administrative work that sort of is being wrapped up now, and hopefully we'll have some results to share at the next PCPCRC meeting in May. So there's a few things that we're looking at, but I thought it was interesting your comment around how, you or those, bereaved family members and how they might care for themselves or the type of supports that they might access. So that's actually something that we're looking at. For example, bereaved parents or caregivers, how do they themselves, are they doing regular, screenings for cancer and, these type of preventative things, like how are they accessing services to take care of themselves? What type of emergency services are they using? What type of mental health services are they using? So that is something that we are looking at. So I just wanted to bring that up. And the other piece that's coming through is that particularly when we're looking at deaths among children and adolescents and the bereavement of parents in those situations, we are actually, we're doing a number of things, but one of the things that we're looking at specifically is deaths related to opioid harms, as well as deaths related to suicide, and drug harms in general, but particularly opioid harms. So we are sort of looking at that, because as you mentioned that, there are some types of deaths that are maybe not as socially acceptable to talk about, right? And what kind of impact does that have on the bereaved individuals who are left to navigate through that? So I just wanted to thank you for your comment. And, if you'd like to, for those of you who don't know, Debbie is one of our patient partners with the PCPCRC. We're really lucky to have her. So Debbie, if this is an area that you'd like to kind of join that group and sort of see the results, please feel free to send me an email, and I'm happy to get you connected there too, because I think everything you've just said, you sort of hit the nail on the head, so to speak, of where we see some of these programs going moving forward.
That's fantastic. Thank you. And I will get in touch with you, because I know you're going to help a lot of people that are silently out there grieving. Thank you.
I noticed that we do have a number of people joining us from other parts of the country here, a lot of fairly strong Quebec contingent, and BC and Alberta as well. And I don't mean to exclude any province if I haven't mentioned you. I don't know all the names that I'm seeing, but I wonder if anyone else from another province might have any reflections on, is what you're seeing here, is this similar to what happened where you work? Is it different than what happened where you work? And in what ways? Would be very keen if, unless anybody has another comment they'd like to make as well. Joshua Black from BC.
Hi, James. You can hear me? Good. All right, great. So yeah, it was a great study. I enjoyed hearing it. Very surprising, some of the stuff that you shared, especially with no one wanting the support in the group at the end of it all. And I think that was with some of the studies that we've been doing at the BC Center for Palliative Care. There was a hesitation for people to do virtual support because it was brand new in the first like 6 months to a year, and a lot of people did wait or were waiting because they thought the pandemic was going to end. And it's when it didn't end, people said, I got to go somewhere. So then they started going. So maybe that would have been some of the reason, the hesitation, that they thought the pandemic was going to end. And then with that, they were going to go for support, but they wanted it in person. And since some of the people were more older, that could also have been some of the hesitation towards that too. That's what we sort of heard within some of the bereavement support providers and what they sort of talked about on also that transition to that, and also even using Zoom and the virtual support, people had to learn about that too. So that, those were the things I was thinking about when you said that people were not that interested in it. I'm curious to sort of ask you about what did they say what they were interested in? Was there ever like a follow-up question to, would you want to be interested in a virtual support group? If not, what would you be interested in?
Yeah, I mean, it's a good question, and again, you're absolutely right. This was a first wave study, right? So it may well have been very different in subsequent waves, and this is still a time when many people are figuring out, how to install Zoom on their computer and that sort of thing. And no, I don't actually have a camera built into my desktop, and so it would have impeded it. We didn't ask any more in-depth question than, because the project was initially a partnership with BFO, and to really work with them on these virtual groups. And so we were really focused on that very much, thinking that we would be interviewing people afterwards and getting feedback like what you're describing. And so it was quite a shock to us to get literally nobody. And I think you're raising some really important potential explanations for why that might be. I think as somebody who's done pre-COVID pandemic bereavement research, one of the things that comes up often when we did qualitative, and the people are like, I got to go down to the hospital, I got to get parking, and it's late on a Tuesday, I can't make it. So the idea that you wouldn't even have to change out of your pajamas, you could do it from your sofa. No pay for parking. I was expecting, some degree of enthusiasm. This was very much not what I expected. So yeah, and it's a challenge, as you say, because what does this mean for the long term? When you literally had nothing to do but sit at home, and many people were, sort of trying to crunch through their Netflix binge watching different series, and here's an opportunity to go to a virtual group just without doing anything more than what you're doing. It's quite surprising.
That's interesting, yeah. And the other comment I had was you did separate the ICG into sort of dichotomized it.
Yep.
I'm curious, did you run the numbers if just using the continuous variable to see if there was a difference?
Yeah, we did. And
oh, you did? Okay.
We did, and there
So
was
nothing.
Yeah.
Wow.
We did a number of different using like increments of increase and decrease. And again, the only one that really came up for us was when we looked at people whose scores started and stayed high, and those who started low but became high, like got more than 4 points worse, right? So the ones we kind of tried to pull out the ones, and this is very much a post hoc, fishing expedition. We found that was associated with people whose loved ones were intubated. But there's no other typical association that we could find. The stuff we were expecting just didn't show up.
Well, interesting. Thank you.
Thanks, Josh, for those questions. Rivka. Hello? Rivka, are you there?
Yeah, I'm here. I wanted to add, I run grief support groups. And during COVID, we started virtual, and those groups were very well attended. We had a maximum of 15 participants, and it was a closed group running for 8 weeks, every 2 weeks. like I said, they were very well attended. They were very, very welcome. The participants felt they were able to reach out to someone and to be able to be supported in their grief. These groups actually are continuing now. We offer them now virtually, and we offer them in person. So we were very successful with the virtual groups.
That's great to hear. Can you tell us? So you said these were 8-week programs with a meeting every 2 weeks. Is that right?
That's right. This is with Hope and Cope, the grief program coordinator, and I'm a social worker. So we run these groups for 8 weeks, meeting every 2 weeks with, it's a structured group. We have a different agenda on each of the session. And then these people sometimes will join other open groups that we have. So they get a very good grief support.
Yeah, so I want to be very careful also when I say this. I can't tell you how many people actually did attend the BFO seminar groups, the virtual groups that did take place, because again, there were a number of people who lost loved ones in other contexts, not the acute care hospitals, but in long-term care and at home, who may well have attended that were just not part of our study. And when you did this, just to Josh's point on the previous question, when did you get these off the ground? Was that in the first wave, or was it in subsequent waves?
You're talking to me?
Yes.
I started it around July 2020.
Okay, so that would have been sort of
the first wave.
Later on in the first wave.
Yeah.
Okay,
Yeah.
So after the initial sort of surge was over, you could well have gotten a lot of people who were part of the first wave. And whereabouts was this? Whereabouts is this?
Pardon?
Where is this in the country?
This is in Montreal.
Montreal.
Yeah. In Montreal, we are part of the Jewish General Hospital, Hope and Cope.
Wonderful. Thank you very much for sharing. That's and again, as much as I don't love make work projects for anybody, but if you guys want to publish what you did and sort of your experience, it can be very helpful for the literature to have some more of that stuff, just simple descriptive and outcomes and stuff. Any other experiences from other parts of the country? Does anybody want to share their own reflections? And again, I'm sorry, we also want to remind that there may have been questions about some of the medication and end of life sort of presence absence, the data that Peter presented earlier, Dr. Lawlor presented earlier. If there are any questions or comments about that, I'd be very keen to hear from you guys. Would be interested also because the practice has changed and evolved over the course of the pandemic, right? So what we did in wave 1 was probably quite different than what we were doing by wave 4 and 5. But this is very much a sort of time capsule. We were going through it for the first time. I found it very reassuring how many people still got an in-person visit in the COVID group. That was higher than I expected, but obviously way lower than what we're used to.
My name is Trish.
Oh, hi, Trish.
Hi, and I am a retired nurse, but in the area of oncology and palliative care is where I practiced. And my own personal experience is that I lost my husband to something other than COVID in long-term care. And my experience was horrific, the worst thing in my life that ever happened to me. And I'm currently undergoing grief counseling. And I think it really, for me, probably the worst part of all of that was being excluded from long-term care. My husband's rights were completely denied to him. I was treated like a foreign object and a vector of some kind of danger. We were, after 25 years of marriage, separated in a way that was abnormal. And I think it's just left me with a great deal of anger. And I suspect I won't be the only one. I think we'll have a whole cohort of people who have endured this kind of treatment. Because you see, in long-term care, people were just absolutely shut out. There was so much nervousness and about, well, we're going to, we can't do anything because we're going to get sued. And, long-term care was very much in the spotlight, and people who were running long-term care were determined they were not going to be one of those people splashed across the news. And so, it was at any cost, and the cost was very great. And I'm pleased that you've done this work, but it's in acute care. And I think it would be interesting to see a similar type of comparison or study done in long-term care. I suspect there's very little data because that's not their strong point. But I think it's great that you're looking at this, and I think there needs to be a great deal more work done, because I think mental illness is going to be a long-term outcome here for a great many people.
Thank you very much for sharing that experience, Trish. And I'm sorry. Again, I'm just really, really sorry for what you went through. And you're obviously not alone in that, certainly throughout the waves of pandemic and the social restrictions in general and visiting restrictions and long-term care were obviously the most stringent, I think, of any place. And as you say, they had rationale for doing it. But I think it was, heavily tilted on the risk-averse side and avoiding liability for them, as much as it was about trying to protect people from COVID transmission from the community, which had a tremendous impact on family members. And as somebody who I went into, I can't even, 16, 17 of the facilities that were experiencing outbreaks. And yeah, I would probably say the moments that really struck me the most, that I remember to this day, were the ones where somebody was obviously passing away and just nobody could come to visit, either because the family members themselves had COVID or the facility just wouldn't let anybody in, no way, no how. And the number of times I would come and visit somebody, and then, there would be family member at the window, because it would be a ground floor facility, for example, and they had just come up to the window and were trying to sort of desperately shout in and say, show some support to their loved ones. But, it was a mess, and there's no two ways about that. What I can tell you is, yes, we don't have the bereavement outcomes for family members of those who lost loved ones in long-term care. What we will get is the health services data. So we are we have the data and are just going to get to analyze it, looking at the outcomes, looking at healthcare utilization among family members who lost people in long-term care. So that we will be able to get a bit more information on. I don't know if that's what you were going to say, Julie, but I'll let you say what you were going to say. You're muted.
I'm struggling. Thanks. So I was just gonna add, and thank you, Trish, for sharing your experience. And as James said, we are doing some work in long-term care. We don't have as granular data in long-term care, so it will be unlikely to be as rich as what we've been able to present today. But like James said, we will be able to look at the healthcare utilization, actually both among caregivers who had someone die in long-term care, as well as caregivers of those who died while receiving home care in Ontario. So both of those pieces are underway. I also noticed there's a comment in the chat, I think from Petra, commenting that they felt they had more support with loss of their son than with their brother. And I just wanted to acknowledge that comment, because I find that very, very profound. What kind of actually brought me to palliative care is worked as a manager at the Ronald McDonald House at our children's hospital here in Ontario. And I worked mostly with parents and siblings. I actually worked with siblings probably more than anyone else. And so we are right now, coming from that experience, trying to look to see if there's a way that in the administrative data we can get some information on siblings. Now, those would be siblings of youth and adolescents, which is a little bit different than adults, of course. But I just wanted to thank you for your comment, because I would agree that when we look at bereavement research, it very typically is around spouses and children or parents, those types of relationships, and less so for siblings. So I wanted to thank you for that comment. And I also, last piece, because there was a question in the chat around how we can encourage and advance social and community interventions to strengthen neighboring and friendships that endure beyond these sort of set 4-week program, 6-week, 8-week program is what I presume is meant by that. And so Paul Hebert, who I don't think is on the call today, is sort of leading a program of work that James mentioned. They're doing a systematic review, looking at community bereavement supports and also an environmental scan of the Ottawa region, at least. And a good portion of that is focusing on what might be considered more informal supports, things like faith-based community groups, for example, that may provide some support that is not in sort of a structured program that might be offered by a hospital or a community support center, for example. So that is something we're looking at. It's harder to identify those and to do research on those because they're not entities that are publishing, for example, right? So it makes it a little bit more challenging. And of course, when something's affiliated with a hospital, there's a bit more of a culture of research and ready access to ethics boards and those types of things. So, so there are some challenges to getting there, but it is something that we hope to look at. So that's what I wanted to add, just as I was sort of monitoring the chat.
Thank you, Julian. Thank you to everybody who contributed to this conversation today. That was really excellent. I do notice that we are at 1:30 now Eastern time, which is the scheduled end for the talk. So I just, on behalf of Peter, the PCPCRC, and all the staff mentioned, just want to give a big thanks to everybody who was involved in organizing the seminar, everybody who was involved in conducting and supporting the research, and I should say the work, not research, but work that was done in this area. And to thank you, all of you, for participating. This has been a really helpful and enlightening session. So really appreciate the comments and the feedback. Everybody be safe, be well, and yeah, I hope you're enjoying the warmer weather wherever you are. Bye, guys.